this morning's Family Caregiver webinar. My name is Carrie McClellan. I'm the Outreach Manager for ElderHelp, and I help to facilitate these webinars and bring different topics to you all. And I look forward to introducing our speaker in just a moment, Dr. Lamb, who is joining us. And so before I do that, a couple of housekeeping informational details. So because this is a webinar, you don't have to worry about your cameras being on, and you are muted. But if you have any questions, we encourage you to type those in. You might see it as chat, or you might see it as question pane. So whichever on your system works, please feel free to type in your questions throughout the presentation, and then we will go through those at the end. So we want to make sure that you get your questions answered. And I'm just going to share a brief about ElderHelp, and then I will introduce our speaker. First, before I do that, a special thank you to Grossmont Healthcare District for sponsoring today's webinar, and a little bit about the Grossmont Healthcare District. So for over 25 years, I wanted to make sure I had that correctly, Grossmont Healthcare District has been supporting ElderHelp's programs and services delivered to East County seniors. So we recognized them in 2017 as our Community Partner of the Year, and we're definitely grateful for their longstanding commitment to older adults. So thank you, Grossmont Healthcare District, for sponsoring today's webinar, and such an important topic and relevant for the work that you do. So our mission at ElderHelp is to support older adults and their desire to continue aging in place for as long as possible. And that not only involves the seniors directly, but also family members who might be involved in their care, making sure they have all of the resources needed to be able to continue living safely and independently in their home. We are celebrating supporting the community for over 49 years now, so we're almost celebrating our 50th, which is a huge accomplishment for a small nonprofit like ours, but we're grateful for our community partners during that process. The core services that we offer through ElderHelp include information and referral, which is connecting people with resources. We offer a variety of check-in call programs, including Are You OK?, which is designed to check in on individuals who might live alone and not have many daily check-ins. So we're able to make sure that they're doing all right and follow up if we're not able to reach them. We offer transportation through our Seniors A Go-Go program through volunteer drivers. Our care coordination program has social workers that are involved, as well as a variety of volunteer services to help older adults continue aging successfully at home. Our housing services team assists with a variety of supportive measures to help individuals find affordable housing. We also have a roommate matching program called Home Share that we facilitate. And our nutrition services offers deliveries from our food pantry as well as grocery shopping assistance. Our family caregiver support program is where these webinars are designed to be through. And through this program, we offer information and referral service to individuals who might be caring for an aging loved one or worried about a loved one and looking for what might be available that they can access. We host these webinars on a variety of topics so that we can bring educational opportunities to you. And we do record all of them, so they are accessible afterwards on our family caregiver page of our website. You can check out our webinar library at any time and see the different topics that we've had in the past. We've also created online courses that are available for a family caregiver, and you can access those on the same web page on our website. And to log in, you would just create that with your email address and a password. You have access to then 5 courses that help you kind of navigate the caregiving journey and figure out what to do moving forward. There's also a course that is on self-care, which is really important for our family caregivers to practice. And we do partner with other organizations in the community, specifically Alzheimer's San Diego and Southern Caregiver Resource Center. So collectively, we are supporting individuals and family caregivers throughout the county and beyond. And now I have the honor to introduce our speaker. And I had the pleasure of hearing Dr. Lamb speak earlier this year, and I thought that the information that she shares would be really valuable to share with all of you. So I look forward to having her do so. A little bit about Dr. Lamb. So Dr. Brittany Lamb is a board-certified emergency medicine physician, dementia family educator, and advocate. In the ER, she sees the overwhelm and stress people go through when having to make medical decisions unexpectedly. Family members choosing on behalf of their person living with dementia have even greater challenges. Outside of the ER, Dr. Lamb supports and educates dementia family caregivers on the importance of and how to plan for future medical decisions. Her goal is to deliver the information needed to make informed decisions into the hands of family caregivers through social media, a blog, and an online program. Caregivers who work with her inside her online program, Make Your Plan with Dr. Lamb, create a medical decision plan unique to their person so they can choose confidently and have peace of mind. So welcome, Dr. Lamb. We're so happy to have you here with us, and we look forward to hearing all of the insight that you have as an ER physician. We don't often get that opportunity. So thank you for being here and sharing your expertise, and I will go ahead and give you the reins.
Okay, sounds good. Yeah, thank you so much for having me. And I appreciate the opportunity to be here and talk with you all. And for anybody who's watching the replay, hi, thanks for coming to watch. So I'm gonna go through a process that I recommend that you all follow when you are when you're trying to plan for unexpected medical emergencies for yourself or on behalf of someone that you're caring for. So you can use this for yourself or somebody else that you're supporting. Okay. So who am I? You heard my bio. So I'm an ER physician. I work full-time night shifts in the ER. I still work in the ER. And a couple of years ago, got pretty burnt out. And it wasn't all because of COVID. It was just a culmination of all the experiences I've had in getting to this point of being a physician and practicing for several years. I just kind of felt like there was more that I could do, that I wanted to teach people, and I didn't really have the space to do and educate like I like to. In the emergency department, it's extremely fast-paced environment. I'm sure some of you have been patients there, unfortunately, or you've been with a family member. So I decided to come online and help families navigate the journey of caring for someone as they're going through a disease that's causing dementia. So I just find that that's a very vulnerable patient population and people need more help. So I'm here as a resource for that, but I also like to educate people who are aging and the people who support them. So we're going to be talking in general today, and I may throw in some experiences with people and clients who are living with dementia. All righty, let's see. I'm getting used to advancing the slides. So, planning for an emergency, it sounds kind of silly, I think, to a lot of folks. It's an emergency. How can you plan for it? The thing is that as we age, we are all at risk of needing unplanned care. It's extremely common. It's more of a when, not an if situation, that at some point you or your person will need to come to the emergency department for care that you didn't really plan for. And there are things that you can do in advance to set yourself up to receive the type of care that you would want. And so I advocate that people make plans based on their risk factors and what might happen to them. And I'm going to kind of touch on that as we go through here. But through engaging in an actual planning process and thinking forward, what this does is it helps you learn, and it helps you learn what's important to you or what's important to your person so that you can communicate that to the care team. And ultimately that turns into you receiving care that you would want. Because what happens is also as we age, when we get sick, oftentimes we get so sick that we can't speak for ourselves. We can't advocate for ourselves. And this is extremely common amongst people who are living with dementia. At some point, they will not be able to make their own medical decisions, but for people who are aging in general, this is very, very common. So it's important that the people who are going to be speaking for you have an idea of how to do that. And it's important for you to be able to do that for your person. So it makes it much less stressful when we have a plan to fall back on when we're prepared. So those are the big benefits of doing this type of work. So I recommend a 5-step process, and I just kind of want to start off by saying that some of this stuff is a little bit heavy, and I also think that it's stuff that you may not be used to being asked to do. So I'm going to try to explain why I recommend that people do these things, and the things that people have told me and reasons why you should do this work, and objections kind of that people have said to me, and what I tell them in response, what I hear quite commonly. So we're going to go through each of these steps, but just kind of to overview them. Step 1 is thinking about what quality of life means to you or your person. Step 2 is taking an inventory and compiling the medical information that we need to move forward. Step number 3 is thinking about what this information and what our lives look like now, what's happened in the past, and what does that make us at risk for. Step 4 is thinking about our goals and our care and what they are now and how they could change in the future. And then step 5 is being able to communicate all of this with your medical decision maker. And at the very end, I'm going to touch a little bit on advanced directives as well. So the task bar on my computer keeps popping up whenever I try to advance the slide. Let me see. Okay, here we go. I think I can move it. All right. Okay, so step 1, we're going to talk about quality of life, and this is something that I think when we all think about quality of life versus like the length of our life, so which thing do we value more? Everybody values quality of life, and everybody values length of life. But at a certain point as we age, oftentimes a lot of folks will wind up valuing their quality of life more than their length of life. And this is what this really comes down to. So what I tell people to kind of think about as an icebreaker, and I would like to put a plug in for the Conversation Project. It's conversationproject.org. I think that they have great handouts on kind of questions that you can ask when you're doing this process with someone else. If you're doing this for yourself, understanding what quality of life and what living means to someone is extremely important. When we know this, it will help us make medical decisions on behalf of this person. So this is not work that you have to do in one day, in one sitting. It's work that you do over time, but it cannot be skipped. It's essential. If we don't know what someone's value is of quality of life, it's very hard to make their medical decisions. So one thing that I recommend people do is just think about this for yourself, talk about this with your person or your people. Is there a difference between living and being alive? And, and everybody has a different definition of these words, but for me, what I mean by living is, you get up and you have a purpose, a meaning, about what you're doing. You enjoy your day. There's things that you're interacting with. There's a reason for you to be up and about, like you're enjoying your life, okay? There's whatever gives you quality of life, you have that. And to me, being alive means that you have a pulse and you're not dead, okay? So that's the difference to me. And so when I ask people, kind of think about that, like what does living mean to you? And then really like what is your value of quality of life versus length of life? So quality versus quantity, and what is that now, and what is that going to look like for you going forward in the future? I think when we actually start to write down and get very like objective about what these things mean to us, it can make a big difference for the people making our medical decisions. So asking questions like, what things can you live with? What things would you not want to live without? What does a good day look like for you? Like just journaling that or jotting down all the things that make you have a good day. What does quality of life mean to you? I asked my grandmother this not that long ago, and she told me several things, and they weren't surprising to me because I think a lot of us hold these things in common. We want to be able to have conversations with people. We want to be independent. A lot of us want to enjoy a good meal. My grandmother was like, I want to have a glass of wine and enjoy a conversation with my friends and family. You know, she specifically told me that she doesn't want to rely on other people for her care. And, you know, but I asked her, well, what if you had to rely on other people for your care to help you get dressed, to help you drive, to help you get your meals, or even to bathe you? What about to feed you? And, you know, she kind of told me, well, Brittany, if I'm able to communicate with them and express my needs and say thank you and tell them that's good, that's bad, that hurts, don't do that. She said, I think I would be okay with that, you know. But maybe some of her medical decisions would change, but that, you know, wouldn't be like a horrible quality of life to her. And so that was an interesting perspective to hear from her. So we all have things that give us quality of life and give us meaning, and actually knowing these things and communicating them for yourself and for your person is extremely valuable. So write it down. All right, write it down, because the other thing I'll tell you is that as time goes on, when people are living with diseases or they're aging, for example, people living with dementia, we tend to kind of forget or not realize as often when we're living with someone or when we're around them all the time that their quality of life has gotten worse because we've gotten used to it. So actually having this written down and having them think about now, but also in the future, what living means to them and what quality of life means to them it's very valuable. But actually writing it down is very important, so you can go back to it. And you can also share that with other people in your family, because there's oftentimes disagreements when we're making medical decisions because there wasn't communication about these things to everyone who is going to be involved. That's very common. So tell everybody. I say have a conversation with your friends about what quality of life means to you too, because I can't tell you how many times I've had clients who have then gone to, you know, they're an adult child of someone that they're caring for who's living with dementia, and they actually go to that person's friends, you know, or their cousin, someone that they're close to, and ask them, what did they say about what living means to them? What did they say about what quality of life means? And they get so much more information out of these conversations. So for us, as we are aging, we need to tell everybody around us what this means to us, because it will help the people make medical decisions for us to come. So it's tell your doctor, tell your friend, tell everybody, tell your family, tell your decision makers. My computer is being so silly. Okay. So step number 2 is I need you all to take inventory of your health conditions or your person's health conditions when you're doing this work. I get a lot of pushback on this. The most common thing that I hear is, doc, it's all in the chart. It's all in the medical record. And I'm here to tell you all that the medical records are like not always accurate. They're notoriously inaccurate. All right. People put the information in there, and it's not always looked at over time and made sure that it's accurate and correct. There are things that are not put in. There are things that are put in that are not correct. We need to take ownership of our medical problems. If we are going to be responsible for making medical decisions on behalf of someone else or helping them when they're not able to do so, we need to know what medical problems they have, because it kind of helps us look forward to the future and understand what things could happen in the future. So I recommend and teach to my clients that a process for gathering all of the medical history. And now it's easier to do this because we have access to electronic medical records, okay? You should have access to your healthcare records. You should have access to your persons. Of course, that could get a little bit more complicated, but all of this can be done online. So you wanna know previous hospitalizations. You wanna know what medical problems the person's been treated for in the past, what they're being treated for currently, major surgeries that they've had. You wanna know medications, allergies. Medications are extremely important to have an inventory of. And this list, a medication list, is essential to be updated and accurate. Our medication lists are not accurate in the electronic medical record. There are so many errors in these medication lists. So I highly recommend that you take time to do this. Take the time that is required to gather this information for yourself, because once you do it once, you just have to update the document as things change. There's lots of benefits to this, and I'm going to talk about some of them just in a second. Okay, so why do I advocate you all do this? There's multiple benefits. There's benefits to you and then also to your person's care team. So for me personally, when I walk into a room and someone has a complete medical history for me, like on 1 or 2 pages, just sits summarized, and they have a complete medication list, I can actually now have a conversation with you, maintaining eye contact, maybe even sitting down in the room and just talking to you. In the emergency department, I do this. I don't have to go to the computer, which for me, I have to go back out into the middle of the emergency department where I sit down at my computer surrounded by other people. Someone says, hey doc, I need you to come get on the phone and talk to this medic about this patient. Hey, there's a stroke coming, need you to come see this patient. Oh, that doctor that you paged is on the phone on line 1, I need you to talk to them, while someone's handing me an EKG I need to sign. It's incredibly hectic. And so in the emergency department, you having this actual compiled data cuts out the computer. I mean, I can read that thing and interpret it with you and think about what tests you may need or what tests your person may need and what they're at risk for much faster than having to look into the computer. Do I still look in the medical record? Absolutely, because there's very valuable information there about what other clinicians, doctors, social workers, nurses have written about you or your person. But you and I can have a much better conversation when you have done this work and you're able to discuss it, okay? So it's also beneficial for you when you're making decisions on behalf of someone else because you have it, you know it, okay? And if you are unable to speak for yourself, having this already compiled will help who makes your medical decisions. So if you take nothing away from this talk, it's please make sure your medication list is updated and that you do a 1-page summary of your medical history and bring it to you at every medical encounter. And just know the EMR, the electronic medical record, is there as a tool, but that you are the owner of your health history. And then also if you're making medical decisions on behalf of someone else, you want to own their medical history as well. Okay, so step number 3 is learning about what you're at risk for, what your person's at risk for. And I've kind of alluded to this a little bit. It's really important when you compile your medical history, because what does it do? It helps us look forward to the future, okay? So how can you learn about what you're at risk for? For example, what do I mean? What do I really mean by this? So say you have high blood pressure, high cholesterol, maybe you have diabetes, maybe you used to smoke in the past, maybe any combination of these things. Well, they put you at risk for heart disease, different types of heart disease, coronary artery disease, where you have narrowing or plaque buildup in your coronary arteries that can lead to a full blockage, which can cause a heart attack. So those conditions put you at risk for that. They put you at risk for heart failure, where the congestive heart failure, where the heart no longer works like it should as a pump. So your heart has multiple functions, so it no longer works like it should as a pump. It also puts you at risk of stroke. So you can look at what medical issues you have and start talking with your doctor about how these things could affect your future. What are the big medical issues that you could potentially face that you wouldn't be able to speak for yourself, that you wouldn't be able to advocate for yourself or communicate what you want to have happen to you? Because these are the things that you can start planning for and start discussing with your family. And you can do this work for your person that you're helping make medical decisions as well. So I say, you can sit down with your doctor. And one thing I want to say here is that you all should know that Medicare covers advanced care planning visits. And advanced care planning is kind of what I'm talking about here. It's thinking about your future healthcare and trying to direct it and to say what you would or would not want in certain circumstances. Medicare pays for that, okay? And a lot of other private insurance companies are going to pay for that as well, okay? So you can ask to have that type of visit with your doctor where you just sit down and do this work. You can also do a medication review once a year as well. So those are things to take advantage of. Very, very important. So you can sit down with your person's doctor to do this work. Or you can educate yourself. So there's great websites out there. Johns Hopkins and Mayo Clinic are 2 of the biggest ones that I recommend for people who are not medically trained. They have very good patient education information. So you can learn about what might happen with the conditions that you have. And I mean, of course, none of us want to think about being sick. You know, we don't want to think about our quality of life being impacted on the way we live on a day-to-day. But I'm telling you all that it's better to think about these things and have a plan for them, and then move on with your life and update that plan as needed, than it is to wait to make medical decisions and think about what's important to you when you're in a crisis. Because that's what happens in the emergency department. People come in and they're in crisis mode trying to make decisions for themselves or for someone else. It's emotional, it's stressful, it leads to a lot of guilty feelings. People feel guilty and they second guess themselves. People feel like whatever decision they made, because they made it in such a heightened, stressful situation and didn't have time to think about it. Naturally, when we care about someone, we oftentimes are going to second guess the decision that we made. And doing this type of planning work allows people who are speaking for you to feel less guilty, more prepared, and therefore less stressed and second guessing themselves as the future goes on, for you, and then also for you if you're doing this work on behalf of someone else. So when you compile your medical history, I want you to educate yourself, and I want you to find a source that you trust to help you learn about what potentially is going to happen to you in the future. It's extremely, extremely important to do. And I know not fun, but it's kind of a one and done and then updated as it goes type situation. So when we learn what we're at risk for, and this is what I teach inside of my course, this is what I teach to my clients because it is so stressful. So I want them to understand what are the conditions their person's at risk for and how are those things treated and what decisions would they make now, and then how would those decisions change as the person's quality of life changes based on their values and goals and what they feel quality of life means to them. So we want to know how conditions are treated. Can they make you very sick? This is a question that you should ask your person's doctor, that you should learn about. So like I was talking about those conditions before, if somebody has congestive heart failure, their heart is not pumping like it should. People live with that for years and years and years, but it can make you very, very sick. It depends on how severe your congestive heart failure is, and it depends on how well controlled it is. It also depends on what type you have, but that's getting into a bit of the weeds. You know, I told you that high blood pressure, high cholesterol, diabetes, smoking, being overweight, those things can put you at risk for blockages in your coronary arteries, which can cause a heart attack. Well, a heart attack is a medical emergency. It can make you very sick because it can make your heart fail. It can make your heart go into a very funny rhythm that doesn't generate a pulse, so you can die. So it can make you critically ill, and so can stroke, like I mentioned before. Strokes can make people critically ill as well. So, you know, once you kind of learn what these things are that you're at risk for, you can learn about how they're treated. And then you can start thinking about whether or not those treatments go in line with your goals of care now and into the future. And you can do this work on behalf of someone that you're supporting and caring for. So step number 4 is talking about goals of care. And I should tell you all that I taught an entire online class about this to people in general on goals of care. It took me about a half hour, I think, to teach it, and it's available online. I can probably share the link with you, Carrie, at the end of this. But and it's a deep dive into goals of care if any of you all are interested in doing more work on that. And I also blog a lot about goals of care. It's foundational work. It's very, very important. But it takes a little bit of time to wrap your mind around. So I'm gonna hit the highlights here. If I can get the, I thought I had this sorted out, but Carrie, can you advance the slide for me? Thank you. So, okay. So goals of care, what do I mean when I say goals of care? What I mean is it's our big picture go-to foundation of the medical treatment, intervention, care that someone's going to receive. It tells us how aggressive someone wants treatment. Okay, if I know someone's goals of care overall, then I can help give the options for treatment that fall underneath those categories. So there are 3 goals of care that I teach. I need your help again, Carrie. I'm struggling with this. I don't know why.
No problem.
Okay, cool. So there's 3 goals of care that I teach, and so every one of us falls into one of these 3 categories. Every single one of us. I think the issue with this is that for most of our lives, we are all full treatment, and what that means is that our goal is quality of life and length of life. We are willing to have care that focuses on prolonging our life, and we understand that that may sacrifice a bit of our quality of life because we want to continue to live. We want the chance to continue to live, and our goal is to have our lives prolonged first and foremost. So the issue I think with this is that as people age, oftentimes their goal of care changes. And as people start to value their quality of life a little bit more than the length of their life, let's say, full treatment may not make sense anymore. And so that's full treatment. On the opposite end of the spectrum, there's comfort care, which is very misunderstood as well. When we talk about comfort care, we're talking about providing treatment, medications, procedures, interventions, that everything about that, the intention of it and the meaning behind it, the first goal of it is to provide comfort first. Now, could it prolong someone's life? Yes, it could. For example, if someone is under comfort care, let's say under hospice care, because people who are under hospice care are typically towards the end of their life. If someone qualifies for hospice care and the hospice nurse practitioner or physician decides to take back some of their medications, they may actually get better and be more energetic and active and feel better and live longer. Another option, another example of how comfort care is not no care, which is what I hear pretty often, is if someone falls and breaks their hip. If someone was walking around, but their goal of care was comfort, they can still have surgery to repair their hip because that's pain control. That's comfort care. And now we have to deal with the complications of that and really think about whether or not it's worth doing all of that for the person based on their unique situation. But that can be considered comfort care. So comfort care does not mean no care. It just means that whatever we do the goal of it should first be to provide comfort. And then the middle group is where a lot of people fall, especially as we're aging. And there's a spectrum in kind of how aggressive someone would choose to have their care in this goal of care category. So the first thing that would make someone not full treatment anymore and decide to be some but not all is if they decide that they no longer want to have CPR. And CPR is cardiopulmonary resuscitation. That's what we do when someone's actively dying. So when they don't have a pulse and they're not breathing, that's when we start CPR, and it's a bundle of care that we provide. And a lot of folks who are aging or living with chronic underlying medical conditions that are impacting their quality of life would be unlikely to survive CPR. And if they did survive CPR, they may live with worse quality of life, and so they may not want that. So when people decide, or you decide on behalf of your person, if you're advocating for someone who's living with dementia and they can no longer make their medical decisions, that they would no longer want CPR, then they would fall into the some but not all group. But just because someone doesn't want CPR when they're actively dying does not mean that they cannot go to the intensive care unit. Does not mean that they cannot be intubated if their lungs fail. So if they have a pneumonia or they have heart failure or they have COPD and we need to take over their breathing and support their lungs, they can still be intubated. So there's different levels of care that people would choose within this group, which is why I advocate that people learn about the medical conditions they're at risk for. Because one example that I like to share with people is you may decide, or you may decide for your person that you would want to have less aggressive care in certain clinical situations. So if a medical situation, in 2 different medical situations, you would pick 2 different types of treatment. So let me give you an example for this. So say a person has underlying congestive heart failure. So their heart's not pumping like it should normally. And that person develops pneumonia and their lungs fail because of that pneumonia and they need support for their breathing. that person may be okay with going on a ventilator to try to get them through the pneumonia with the goal of trying to return them to the quality of life that they had before. That might be their goal of care in that situation. They may be okay with that. But let's say that same person has learned about congestive heart failure and about how it oftentimes gets worse over time, and that we can't reverse those changes that get worse over time. And so it impacts the person's quality of life. And as it gets worse, their quality of life gets worse. So if that person has a situation in which their lungs fail because of congestive heart failure, they may decide that in the situation like that, they would not want to go on a ventilator if their lungs failed for congestive heart failure. So this is why I advocate for looking at the conditions we're at risk for and actually creating your own plan for what you would want in certain circumstances based on your risk factors and your goals, and helping the people who are going to make decisions for you know what you would want in the future. And it all comes back to what quality of life means to you, and having them check in and make sure that you're still living with the quality of life that you would want to have these certain treatments and interventions. So that's goals of care in a nutshell. I will make sure that I share the link with you, Carrie. I need you to change the slide for me. I can see it when you do. Okay, so tipping points is a concept that I also teach. And basically, this is what I was talking about with making sure that we're paying attention to quality of life and what that means for a person, because everybody has different values of what quality of life means to them. And so each of us have different situations in which we would want to go from full treatment to some but not all, from some but not all to comfort. And I recommend that people write this down and think about this once they learn about goals of care ahead of time. Because like I said before, it gets hard as someone's quality of life gets worse. It gets hard for our decision makers to recognize that. And it gets hard for us to recognize that on behalf of somebody else. So tipping points are things about your life that you would say would put you into a different goal of care category. And it might be different for everybody. But like, say somebody would say, well, if I can't live independently anymore, if I physically cannot live independently anymore, I don't want to have CPR. And so then they go from full treatment to some but not all. And then they may say, when I can no longer, when I'm no longer able to communicate my needs and my desires and my wishes, I want to be comfort care. And those are just examples. You know, it depends on the person and their situation, but you can, when you start to learn about the diseases too, as diseases change and progress over time and can impact quality of life, that can also impact and kind of help you update what your tipping points would be. So this stuff all kind of comes together. It's a process. Okay. All right, next slide, Carrie. I give up. All right, so step number 5 is communicating all of this with your medical decision maker. Okay, you can do the next one. So if you have not chosen a medical decision maker, you want to choose someone who will follow this cardinal rule that I teach people about. And that is that when we make medical decisions on behalf of someone else, we have to do this for them, speaking as if we were them. So we are their voice. We are making the choice that they would make. Now, the caveat here is that we are able to take in what's going on. We are able to think about what's actually happening to the person and to apply that information to their situation now and how they've been living. We're able to actually talk to the care team about how likely is it that they would return to their the way that they've been living and their quality of life. We're able to ask the questions to become informed in order to make the decision that we think they would make, and then we speak on their behalf. So you want to find someone who is willing to do this for you. And if your person that you've chosen, you're thinking in your mind, I'm not sure that my person can do this, then you need to go out seeking someone who might be able to help you with this. For those of you who are in a situation in which you are aging independently, or your person that you support is, you're not their medical decision maker, and maybe they don't have anybody else, I will say that there are services, actually, aging life care managers that can provide this type of service. I think it's easier easier and more normal. I hate using that word, but it's more natural to a medical professional like me to be looking for the medical decision maker who's typically family. And there is a default decision maker if one is not chosen. Each state has its own hierarchy of who would step in and make medical decisions. And typically it's spouse and then children second. And then I think it's a parent if they're alive, and then siblings. That's usually how it goes. But you can look that up for your state. I just want people to know that there are services that can be your medical decision maker. Okay. And then, when you choose your medical decision maker, you want to talk to them about this whole process that you've gone through. What does quality of life mean to you? Talk to them about all of your medical problems. Talk to them about what those things put you at risk for. Have them help you do this work maybe. If it's too stressful for you, maybe there's someone in your family that would be willing to help you do this work. Maybe not even someone who's your medical decision maker. And then talk to them about your goals of care and quality of life. And so for those of you who are doing this work for yourselves, that's what you need to do. But if you're speaking on behalf of someone else, you also want to do this stuff. And the person who's making medical decisions for someone else needs to be updated over time. They need to be let in on what's going on and as things have changed. So if there's been a new hospitalization, if a person's functional abilities have gotten worse, so now they're having trouble driving, now they're having trouble walking, now they're having trouble cooking, whatever it is, we need to check in and make sure that our plan makes sense. And also, I stress that if you pick a medical decision maker, you need to tell them why you chose them and let them in on all of this. But you also want to think about the other people that may come out of the woodwork or not come out of the woodwork because they're part of your family and you're all involved. You want to make sure everybody understands why you chose this person. And also, if there are people that you do not want to speak on your behalf, you should tell your medical decision maker. And another thing is that it's usually a good idea to have a backup medical decision maker because things happen, especially with spouses. I find that very, very often that the medical decision maker for my patient is their spouse, and their spouse can't make their medical decisions because now they're living with dementia. Or I even had a situation, I can't remember how long ago it was, but I had a husband who was very, very sick with I think he had a flu. He was really sick. He was on oxygen. He had a high fever. And his wife was also sick, but not as sick as he was. She was living with dementia. And he was so nervous because at that time, he was able to make his own decisions, but he was worried about his own medical decisions. And then he was worried about what would happen to her if he wasn't able to speak for himself or if he wound up on a ventilator. And I talked to him about this at length and wound up documenting a lot of stuff that he said just in preparation because they really didn't have any other documentation to support her kind of plan going forward, or his for that matter. But side note, so those are some of the key things that I think people kind of make mistakes and can do better when they're choosing a medical decision maker. Okay, next slide. And then the last bit of this is kind of step 5.5, is that you want to make sure that if you have advanced directives or your person has advanced directives and they're still able to do so, that these documents are updated. So we want them to be accurate because I can't tell you how many times I've read documents that do not actually reflect the way someone's been living. This is extremely common when people are living with dementia because at a certain point they won't be able to update their advanced directives. I like the 5 wishes over the living will, over traditional living wills. I like the 5 wishes, but I do want you all to realize that these documents are tools, but they are not a plan. So what I've taught you about learning your medical history and what it puts you at risk for, learning how those things are treated and starting to think about what types of treatments you would or would not want in different situations, that stuff doesn't usually go in advanced directives because that's not how they were designed to be used. Advanced directives can help us understand what someone's goals and values are, but they're legal documents. They're up for interpretation. They're not a plan, they're a tool. I still think that they're valuable to look at and to have if we're able to. And 5 wishes I like better than the traditional living will. There are also dementia specific advanced directives for people who are interested. There is a psychiatrist that works in California. I feel bad, his first name is Stanley, and I'm blanking on his last name, but he has a whole program that helps people create a dementia-specific advanced directive. And so I can share his information with you, Carrie, after this. I can email it so we can share his information. I do also know of a emergency medicine physician who created a program doing video advanced directives, and that's called MIDEO, M-I-D-E-O. I've gone through that. I've gone through both of their processes and recommend them. So, but a person living with dementia at some point will lose the ability to do this work. So it is important to do. I just don't want people to stop there. There's more work that you can do, because none of these documents that are created, because they're legal-based documents, the legal jargon in them is very hard to actually turn into what are we going to do in these specific circumstances. So I recommend that you create a medical decision plan separate, and that's communicated with the people who are making medical decisions, in addition to having advanced directives if those are available. Customizing them if we can, but you have to be careful when you customize them, because if you write something in there, people are going to want to follow that, and if it's not able to be updated, it may not be accurate anymore. So you have to be careful with them. That's why I recommend these two doctors that are doing this work. And then don't forget to declare on an advanced directive. The other two types of advanced directives, we have ones that tell us what type of care you would or would not want if you're not able to speak for yourself, and then ones that allow you to declare who you would want to make your medical decisions. And one of the most common names for that is medical power of attorney. So make sure that you fill out that document, because that's who I'm going to be calling. Okay, next slide. Yes, so that is the spiel. That's my process that I recommend. If you all are interested in connecting with me, I think the easiest thing to stay connected with me is to sign up to receive my emails, and you can do that at my website. It's blambmd.com. And then also there you can follow me on social, and you can look at my course and my blog. I think my blog would be valuable for a lot of you. So I'm happy to take questions. I know that was a lot of information.
Thank you so much, Dr. Lamb. That was a lot of great information. I especially appreciate all of the examples that you provide, because I think that can help people think about their own lives or the person that they might be caring for, and can put it into perspective. So thank you for sharing your 5 steps and all of the information and examples that went along with that. I feel like it was a really thorough explanation of the why also.
Thank you.
Which is important. I don't see any questions coming in yet, so I am going to move forward in a couple of slides, but for those of you that are on, feel free to still submit your questions. If you have something that you would like to ask Dr. Lamb, you're welcome to type those in, and I will stop at any point. I'm just gonna move through just so that we can get to the end of this, and then I will share our resources as well for follow-up. And as a reminder, I will be sending a follow-up with the recorded link of this webinar, in addition to the resources that Dr. Lamb has. So I'll make sure to include that in the email so that you can have easy access if you didn't have a chance to write things down from her slides. So I will be sure to do that, so you'll have all the information at your fingertips.
No, I threw out a lot of extra stuff there. I'm going to try to write down what I said.
Okay, thank you. That would be helpful. I know it would be good to include those resources as well. So thank you again for that. And also thank you again to Grossmont Healthcare District for sponsoring today's webinar with the relevant topic. We do have another webinar that's coming up in July, so it'll be middle of the summer, and it will be about medication management. So we are going to do that in partnership with Alzheimer's San Diego. Medication management is something that comes up a lot with family caregivers in different situations. So that topic I think will be relevant for many of you. So please tune into that if you are interested. And then I wanted to also mention, as part of the Caregiver Coalition of San Diego, we have an upcoming webinar that will be taking place next week, so Thursday, June 15th at 11 o'clock, and it will be on the topic of mental health and mind-body connection. So there's a couple of different speakers that are through Jewish Family Service here locally, and they will be sharing about that topic. And so I encourage anybody who's interested to check that out. I will include that information in my follow-up email as well, so that you have those details and the link to join via Zoom. And then just as a final slide, if you have any general questions or you missed something and want to know more, feel free to reach out. Our main phone number is on the slide. I'll leave it up for a couple of minutes. We also have our email address that you can reach out to. If you are not yet signed up to receive all of our family caregiving webinars and want to know about them as we schedule them, please send me an email or respond to my email when I send the follow-up, and I'd be happy to add you to that list so that you are automatically in the know. And our website, elderhelpofsandiego.org, has all of our program information, as well as our family caregiver page, where you can access the recorded links for the past webinars, as well as our online courses. So definitely check that out. And I do have a question that came in. And first I had a comment, just somebody thanking you so much for the information.
You're welcome.
Helpful. So this person, let me see what the question is. So their person signed a DNR without knowing what he signed. They reversed that one, but a year later, they were trying to get him to sign another. How can the caregiver make sure that hospitals don't have patients sign DNRs without notifying family?
That's tough, because if a person has capacity to make their own medical decisions, then they're allowed to sign a DNR. And even if they have a medical power of attorney really only goes into effect when someone no longer has decision-making ability. So if the person doesn't have the ability to make their own medical decisions, they should not be able to sign a DNR. When someone is earlier on in the stages of living with dementia, it can be hard for medical professionals to know that that person has lost decision-making ability. So what I would recommend is that you talk to, if that is the case, if it is dementia, if a person has lost decision-making ability really due to whatever disease or illness, but living with dementia is very common, is to talk to their doctor about getting a letter written that says that they have permanently lost decision-making capacity. Then you have that on file with the hospital. You tell them to flag it and say, hey, look, like, they can't sign their own documents. They cannot give informed consent. And you have to be able to understand what you're signing in order to sign a DNR. So that's all idealistic, right? Like, that's what should happen. But I know this happens, like you're telling me this happens, but it happens because we don't know the person like you do. And when they're able to answer what year it is, where they are, who they are, what their birthday is, and they're able to, like, say back to you that this is a form that means that I'm not going to get CPR, it can appear that the person has the ability to make their own medical decisions. And so medicine is not black and white, it's very gray. So in that situation, if you believe that your person doesn't have the ability to make medical decisions, I would ask for a letter stating such, so that can be on file at the hospital.
It's a good recommendation. Thank you.
It's a tough situation.
Yeah, I'm sure it comes up quite a bit. And I know there's so many people who are kind of in those beginning stages, like you're saying, that can answer certain questions, but do they really fully understand what is being asked and what the form indicates? Not right. Necessarily if you were to ask them 10 minutes later, but at the time maybe.
Yes, so that's the problem too, is that capacity fluctuates. Yeah. So at certain times of the day, someone may have decision-making capacity, and the other thing is too that once a person does sign their own do not resuscitate, we are really not supposed to overturn that. So most states have a law actually saying that you're not to do that. So if someone else is coming in to make medical decisions, then they're not supposed to overturn the DNR. But if it was done when someone didn't have capacity and you're able to document that and prove that through like the medical record, then that would make sense. But it's very gray. It's very gray. Tough.
I'm sure there's so many different situations. Well, I don't see any other questions coming
Okay.
in at this time. So I think you covered a lot of really helpful information and gave people the tools to be able to start thinking about all of this. So I will again include all of the information in the follow-up so people can have your details and how to reach out to you if they have any further questions specifically. But thank you, Dr. Lamb, so much for your time today and sharing all of that wonderful information. Although it's difficult, I think that it's important for us to talk about. So thank you for doing
Yes. No, thank you for having me, and thanks for everybody who's here and anyone watching in the future.
that. Thanks so much. Take care.
Bye.